So I want to thank you, Dr. Spies, for providing us with this lecture this evening. This is the first of our lecture series that we're calling through the SIR. This is our resident fellow section, and we came up with this idea of evidence-based lecture series where we'd like a IR physician who's very knowledgeable in the research of certain topics to give kind of a background of groundbreaking trials or any sort of evidence that we can use to use in our future careers. So I want to thank you again for providing us with this lecture tonight, and you can begin when you're ready.
Okay, well, can everyone hear me okay?
Yeah, hi, Dr. Steve Huffman here. Thanks very much, Rob. Sorry I got in late here. I'm trying to log in online, and it's not letting me, so I just called in, but hopefully I'll be able to log in here soon. But thanks again for the nice introduction, Rob, and thanks so much, Dr. Spies, and we look forward to your talk.
Okay. Well, first of all, I'd like to thank the Resident Fellows section. It's actually kind of an honor. I didn't realize this is the first lecture. It's kind of a high bar for me now, and I'm going to have to, this may be the last one after you get done with this lecture. We'll see. So as many of you may or may not know, I've spent a good part of my professional career both practicing in fibroid management, but also doing a lot of research, and been very interested in the evidence that we've developed for fibroid embolization. So I'm going to give a little overview of that. I don't think, for those who might be disappointed, I don't think this is going to last an hour and a half. I certainly am happy to take questions that long, but I think that we're probably going to be looking at, if I can get my slides to go. There we go. I have to use my magic mouse, I guess. So what I would like to do is just take a minute to do a little background on how patients with fibroids present, so you all have sort of a common sense of uterine fibroids. Not a great detail on that. Then do a little technical of the procedure itself that we normally do, and then we're going to review the evidence, and that really is the main part of this lecture. So uterine fibroids are ubiquitous in women, and about somewhere between 70 and 80% of women will at least pathologically have fibroids identified at the time of hysterectomy or at autopsy. So they are very, very common tumors. The majority of them don't cause symptoms, but a substantial minority of women will have symptoms that require therapy, up to 20 or 30%, depending upon the patient population. So the fibroids typically cause heavy menstrual periods, severe menstrual cramps, pelvic pain, back pain, maybe more commonly pressure or abdominal bloating than true frank pain, urinary frequency, urgency, occasionally retention. I saw a patient today with intermittent urinary retention, and then difficulty becoming pregnant or carrying a pregnancy, so subfertility in general. So fibroids are benign muscular and stromal tumors that really exert the symptoms they cause based on their location. So those that are deep, that distort the uterine lining, will cause heavy bleeding typically. The bulk symptoms are related to all the fibroids causing enlarging the uterus in general. And there may be focal pain over one specific fibroid, say on the right side if there's a large fibroid in that particular location. So currently, looking at the choice of treatments, hysterectomy is by far the most commonly recommended and performed therapy for symptomatic fibroids. And actually, these estimates are probably a little bit behind the times. I would estimate that about 350,000 hysterectomies are performed each year in the United States for fibroids. That's probably between 40 and 50% of hysterectomies in the United States are for that purpose. About 40,000 myomectomies are estimated each year, and about 20 to 25,000 uterine fibroid embolizations. So just looking at this, fewer than 10% of hysterectomies are the patients. In other words, 1/10 the number of patients that have hysterectomy have uterine fibroid embolization. And you might ask the question, why is that, given the evidence base I'm going to present this evening? Myomectomy is more common in women in their 30s to preserve the uterus. It usually does not compete directly with uterine fibroid embolization. And again, I will talk a little bit more about the relative outcomes of fertility outcomes after myomectomy and embolization. The truth, though, is that uterine fibroid embolization can be safely and effectively used in most patients, and certainly could substitute for many of the hysterectomies that currently occur. So, just for those who don't know, and I know that we have a mixed group and not everyone has been through angio yet, but this is a bilateral embolization of the uterine arteries. At Georgetown, we actually do bilateral femoral punctures, but in most centers, a single right femoral puncture in which the catheter is advanced over to the opposite side, embolization performed, and then the catheter, through various maneuvers, moved into the right hypogastric artery, and then an embolization performed on that side. And nearly all patients will require bilateral embolization. The exception are those patients who have a single fibroid, like in this diagram, who might benefit only from embolization on one side. So that there's some evidence that can be reasonable in very restricted circumstances. So what is the theory behind embolization? Well, what we're trying to do is block the branches to the fibroids only. The branches of the myometrium are much smaller than the perifibroid branches, and therefore the fibroid branches have most of the flow initially, and that's where most of the embolic material goes. So the trick here is to embolize the fibroid branches, and you don't really need to occlude the entire uterine artery. And in fact, there's some evidence that may increase the risk of endometrial injury or perhaps increase the severity of pain after embolization. And we won't get too much more into the details of this other than to show you that this is a typical patient. The initial image over here is a sagittal T2 weighted MRI image, and it shows multiple fibroids here in a uterus. This is how the angiogram looks, bilateral injection before, and this is how it looks afterwards. So you can see that we really did prune the tree here. Most of the major branches are still patent, but it's these smaller fibroid branches that have been occluded. And this is a contrast image 3 months later, and all these fibroids are completely avascular, and they're diminishing in size, and the patient's symptoms had regressed. So that's a kind of a typical outcome that one would see in the short run. Now, I'm having just a little trouble changing my slides, so forgive me if we go over one. So this is, again, a typical circumstance. We did a study many years ago looking at how patients did longer term. And if the short answer to this all is that if you infarct all the fibroids, and all these 4 last images are contrast images showing black fibroids, meaning that they are completely avascular, that you'll get progressive reduction in size of the uterus over the course of time, and there will not be a recurrence of those individual fibroids. If a fibroid is completely infarcted, it will not regrow. However, you can develop new fibroids. This is another example. This was a 7-centimeter intracavitary fibroid. You can see it's smaller, probably 4.5 to 5 centimeters. It's reshaped itself at a year. You can see at 2 years, it's almost completely gone. At 3 years, and then at 4 years, we really have normal uterus. So that patient actually had that fibroid essentially completely dissolved, likely passed with their cycle, never really had an event of fibroid expulsion, but in the end ended with a normal uterus. A little bit unusual, to be honest. So if one was going to ask the question, what is the evidence for UFE? And first let's take a stop and say, well, how does one actually find evidence? And in most methodologic circles, evidence from property design clinical experiments is what people are looking for, which in essence means randomized trials. And why is that? Well, randomized trials completely eliminate selection bias as an issue. It doesn't mean that there won't be some differences between the groups that are randomized, but it means that it will be due to random chance. So one of the big pluses for randomized trials is you can take a group of patients that have particular characteristics, and if they're randomly assigned, whatever variations they might have between them are randomly put between the 2 groups, and therefore, from a statistical perspective, no longer are an issue. So the other night, I actually did a repeat search in this. I've done this a couple of times over the years, and put in just the terms uterine fibroid embolization, and a all capitals A and D, and then randomize into PubMed. And 97 articles came up, although many of those articles were really either not on topic or were reviews that included randomized trials. So this particular set of studies, these 32 articles, were what was yielded from that search. And these were 32 articles that were original papers associated with randomized trials. And so they're not summations, they're not reviews, etc. And of those, 22 articles were from studies that compared one treatment to another. Now, if you look at this carefully, you'll see that the REST trial has 4 articles. The Emmy trial is sort of the granddaddy of all articles. They had 9 articles written about that one group of patients. So if you were just to count up the randomized trials that have been published to date, you have 1, 2, 3, 4, 5, 6, 7. There are also 4 more articles that are quite small. One is sort of moderate, and this is regarding laparoscopic occlusion of the uterine artery versus uterine fibroid embolization. All these others are versus either hysterectomy, myomectomy, or some combination of both. And so in the big world of trying to determine, well, how does UFE stack up against those other major and much more common interventions, those are the studies that we want to focus on. Now, again, the 2 studies here that are probably the best known and the most quoted are the REST trial and the Emmy trial. So those are the ones that I'm going to concentrate on. I should also mention that there are additional 10 articles, and we've actually done some of them and others have as well, on technical approaches, which embolic is better than another. We did one on unilateral femoral puncture versus bilateral femoral puncture. There have been studies done on pain control and other issues. So there are technical questions that could just as easily be answered in randomized trials, but we're not going to concentrate on those, because what I want to really focus on is what is the argument for uterine fibroid embolization based on what most people will consider to be good quality evidence. So let's start with the REST trial. So this actually was the second of the major trials that was published, but it probably got a little bit more press, in part because it was published in the New England Journal of Medicine, which of course is very prestigious. So this is a randomized multi-center study that was completed in the United Kingdom, and there was a comparison of uterine fibroid embolization versus surgery. And it was either hysterectomy or myomectomy. It was sort of surgeon's best choice. In other words, what was the best thing for that individual patient? So in this study, they did a 2-to-1 randomization, 2 UFEs for every surgery. And of course, they don't work out, the numbers don't work out exactly perfectly because, of course, they're randomly assigned. But the majority of these surgeries were hysterectomies. 43 were hysterectomies, 8 were myomectomies. And that just has to do with the patient population. And to sort of summarize this study, the 5-year outcomes were recently completed. And if you look over the course of 1 year and the 5-year outcomes, the symptom and quality of life outcomes were very similar on an intention to treat basis. So what does that mean? So these patients were randomized. They underwent some therapy, or maybe they didn't. So for example, if you were randomized to surgery, and you said, well, I'm not going to have surgery, and then you went off and took herbal medicine or something, you would still be considered in the surgery group, and your analysis would be based as if you had undergone the surgery. So therefore, the intention to treat was surgery. Therefore, anything that happened to you afterwards was included. Now, this becomes an important issue potentially on the UFE side, because the patients that underwent UFE, if they had a re-intervention, still their quality of life would be measured, and it would be measured as if they had just undergone the UFE alone. So looking at this overall, if you just said, how are your symptoms, how is your quality of life using validated measures, the results were very similar at 5 years. However, the re-interventions were higher with UFE. 26% of patients required some re-intervention for either recurrent symptoms or failure to improve by 5 years, 0% in this particular study for surgery. So, looking at the Emmy trial, which is the trial from the Netherlands, which had so many articles written about it. So 177 patients, 88 were UFE and 89 were hysterectomy. And again, if one looks at the 5-year outcomes from this, there were no differences in the SF-36 quality of life scores. UFE patients did have a significantly higher re-intervention rate. 28.4% of patients underwent hysterectomy. Among the hysterectomy patients, 10.7% needed re-intervention. And that means intervention for adhesions or perhaps pelvic floor prolapse or complications that might have occurred. So this study is a little bit more real world in that regard, in that there are patients after hysterectomy that need additional surgery. There's another interesting fact about this study. I wrote a commentary about it a number of years ago. This was unusual in that they recruited these 177 patients from 35 different centers, and the vast majority of those centers had never done UFE before. These were their first cases. And so most of the centers recruited less than 5 patients, and some only 1 or 2. And those patients were cared for by the gynecologist. They were admitted by the gynecologist and cared for them. And so there was very little experience base among those centers. Now, they had an interventionist come from one of the larger centers to stand by during the procedure. But really, these are patients that were sort of on their own when it came to peri-procedural management. And so they had worse short-term outcomes in terms of readmissions and also minor complications, and I think in large part that can be explained by the inexperience of the gynecologist taking care of these patients. So those are 2 of the big trials, but when one thinks about evidence, one wants to look at a broader concept, which is a systematic review. And systematic reviews classically involve an analysis of all appropriately performed randomized trials that would meet certain entry criteria that you would set up. So when you do a systematic review, you actually write a protocol and say, these are the inclusion criteria for studies, these are the exclusion criteria, and then they would go through, or they do extensive literature search, and they come up with these studies that qualify. The sort of granddaddy of these is the Cochrane collaboration, which is an international collaboration of researchers, methodologists, clinicians, who write systematic reviews on a voluntary basis on a huge variety of different topics. There's about 4,000 Cochrane reviews out there. The first one in UFE was written, I think it was in 2005 or 2006, and just this past summer, the 2012 revision of it was completed. So the most recent one included 6 randomized control trials, a total of 732 women. 3 of these trials compared UFE to hysterectomy, 2 trials to myomectomy, and 1 trial compared it to best choice, which is the REST trial, meaning either myomectomy or hysterectomy, depending upon patient choice or physician choice. And if one looks at the results from this review, and this is a meta-analysis, and this takes the results from all those trials and puts them together, they found no difference in patient satisfaction between the 2 groups at 2 years or 5 years. They indicated there was moderate level of evidence because 5 of these 6 trials measured that at those intervals. Quality of life is very similar, although it was not completed out to 5 years in every trial. There was weak evidence in that only 1 trial provided evidence for that review. Let's see if I get this to go forward. Myomectomy may be associated with better fertility outcomes, and again, they said it was low-level evidence. 1 trial, and I'll go over that trial in a few minutes. They found no difference in major interventions. The initial cost advantage of UAE may be balanced over time by higher reintervention rates. So UFE has a shorter hospitalization, has shorter expenses associated with it, or fewer expenses associated with it. But there is a higher reintervention rate. The 2 trials I reviewed and others have shown the same thing. It did also indicate, though, that ovarian failure is not more likely in uterine embolization than it is in hysterectomy when the ovaries are preserved. And that's an important issue because some people have become to believe that ovarian failure is inevitable after uterine embolization and that it never occurs after hysterectomy, and that's sort of the opposite of the truth. So the key things, though, if you were to compare UAE to surgery, UAE has a shorter procedure time, shorter hospital stay, and resumption of routine activities is more rapid. And there's a decreased likelihood of transfusion. This is what they found. UFE had a higher minor, short-term, and long-term surgical intervention rate, more unscheduled readmission. Again, think back to the Emmy trial that contributed a lot of patients to this. They had an 11% readmission rate, much higher than any other reported study. And they had UFE patients had an increased surgical reintervention rate. And that's not disputed by anyone. I think that that's been shown across the board. This is compared primarily, again, to hysterectomy. Now, there are a number of additional studies. There's one from the Netherlands. There's a study that we published of 200 patients. Woody Walker from the UK, Gabriel Cox is from the US. Large numbers of patients, long-term follow-up. And you can look at the hysterectomy rates over here, ranging from 5% to 19.7%, and the overall recurrence rate needing some major reintervention, in this case needing either hysterectomy, myomectomy, or repeat embolization. You can see it's in the 20% range. And that's very similar to the rates that we saw in those randomized trials for reinterventions at 5 years. So, how does that compare to anything else? Well, there was an interesting study that was published a number of years ago in the Journal of Women's Health. And what they did was they took a group of women that had undergone myomectomy between 1993 and 2002 in a Seattle-based HMO. And these were all women that were continuously enrolled in this HMO, and therefore they had complete, in theory at least, complete medical records. And they looked at repeat surgery rates for women who had undergone myomectomy. And among the 628 women, 21 or almost 22% had a second surgery. 75% of these were hysterectomies. And if you look at the cumulative incidence of second surgery using a life table analysis, you have 23.5% of patients at 5 years and 30% at 7 years had a subsequent intervention. Very similar to what you might see with uterine embolization. The annual incidence of subsequent surgery after myomectomy was about 5%. Again, you'll see later in this that that's similar to what we see with UFE. Now, we did a study at Georgetown and a number of other centers looking at symptom and quality of life scores, and we decided that we were going to try to determine how likely women that undergo these treatments will have their symptoms return to normal or near normal. So what we did was we had a group of 101 normal patients, and they filled out a series of questionnaires, one which is the questionnaire we were revalidating called UFSQOL, and it has a symptom score. Normal symptom score here is 15. Lower symptoms are better, or fewer. Why would you have symptoms in a group that are normal? Well, because most women have menstrual symptoms. The scale is from 0 to 100, 100 being horrible symptoms, 0 being no symptoms. Quality of life scores are the opposite, in which 100 is the highest possible quality of life and 0 is near death. And you can see that among the baseline group, we had 274 fibroid patients. About 65%, or 65 was the baseline score, way higher, much, much worse than normal patients. And you can also see the quality of life was much lower, so this corresponds. If you look at this 12 months later, after all these patients were treated, you can see that the mean scores, symptom scores, were not different between the fibroid group as a whole and the normals. And you also can see that there was much improvement in the fibroid quality of life scores, although you'll see that the normals still had a little bit higher quality of life. The interesting part of this study is that if you go back and look at the, let's see if I get this moved, there we go, 12 months after therapy, these are the normal scores, 15, 94. If you look at UFE, 24.9, 83. So not as good as normal, not quite as high as normal. Look at the myomectomy patients. No difference between UFE and myomectomy, 23.4. Look at the quality of life scores, essentially the same. Not quite normal, not quite as high as normal. But if you look at hysterectomy, you'll see that the scores are actually supernormal for symptoms, and they are essentially identical when it comes to quality of life. Now, why is that? Well, first of all, hysterectomy works. And so women's quality of life is generally pretty good after hysterectomy, number one. Number two, this questionnaire has lots of questions about menstrual bleeding, etc. And, of course, if you've had a hysterectomy, you don't have menstrual bleeding, and therefore you score 0 automatically. So in some ways it's a false claim or that hysterectomy gives you supernormal scores. But we use this so that we can validate this questionnaire against hysterectomy and normals, so that when subsequent studies are done in the future, people will have some frame of reference to look at. Let's see if we can get this to go. There we go. Oops, go back a second. So then we need to talk about complications, and there was a recent meta-analysis, in fact it was just last month, AJR. There also was one, coincidentally, almost the same exact topic and same method in the cardiovascular and interventional radiology last month. But I chose this one as a bigger study, had a lot more, I think methodologically was a little bit more rigorous. So what they did was they used a set of criteria, and they went out and identified studies, and they found 54 patient studies that met their criteria for a total of 8,159 patients. And they determined that the major complication rate after UFE, based on that summation of all that data, was 2.9%. There were no deaths. A hysterectomy for complications occurred in 0.7% of patients, and the readmission rate overall was 2.7%. So see, this is the value of this. You have 54 studies, 2.7%. Remember the Emmy Trial, 11%. Now, so, but none of these studies, or most of these studies, would not be included in a standard Cochrane analysis because they're not randomized trials. Reintervention rates, 5.3% per patient year for follow-ups. You'll remember on the myomectomy paper I mentioned a minute ago, it's 4.6%, so it's essentially the same in this meta-analysis. So then what are the complications that can occur? Well, in this summation, we saw that readmission occurred in 2.7%. Menopause was caused, or the onset of menopause occurred directly as a result of embolization in about 4% of patients. Fibroid passage or infection related to vaginal discharge after this was in 4.7% of patients. This is the most bothersome, most difficult management problem that we faced. And both a paper by Rich Slansky and a recent review that we did of our numbers show that our rates were very similar to this. So you can anticipate on average about 5% of patients will have this occur. Now, some patients will not have it ever occur because of the location of fibroids, where some people with very large fibroids intracavitary are very high likelihood. So even though the average might be about 5%, the risk will actually vary based on fibroid location. The frequency of hysterectomy for complications, I said, was 0.7%. Infectious complications, I presume that does not include related to fibroid passage, in 2.5% of patients. Angiography-related complications at the time of the procedure, maybe misembolization, arterial injury, whatever, about 3%. And pulmonary embolus deep vein thrombosis, 0.2%. Our own experience is very similar, about 1 in 400 patients. Death, this paper reported no deaths, and no deaths have been reported. The truth is that there are only about 4 or 5 deaths that have been reported in the world's literature. I personally am aware of at least a dozen in the United States. Nearly all of those are related to pulmonary embolus. And how I found out about those is that people would come up to me at meetings at the end of a lecture and say, geez, you know, have you ever heard of anybody dying from a pulmonary embolus? We had a patient die 24 hours after this procedure. Of course, they don't write it up, and so we don't really have those numbers. We don't have a sense of what the frequency is. But I know that at least 8 or 10 people have come up to me. I'm aware of one in our local area that a patient died from this. So for this reason, people need to be aware of this, and they need to take prophylactic measures. We typically, in order to try to avoid that, use pneumatic compression devices, and we also screen patients for hypercoagulability with a questionnaire. And if they have a family history or personal history, we do give them prophylactic Lovenox. So what about fertility? Well, there was a study done in Prague. It was one of those randomized trials I mentioned. It was by Michael Mera. He was the first author of both the publications that have come out to date. It's an interesting study, and I'm not sure you could be able to do this in the United States. He had 121 women, all of whom wanted to become pregnant, mean age of 32. And they were randomly assigned to uterine fibroid embolization or myomectomy. There are 63 myomectomies, 58 UFEs. And looking at the midterm pregnancy results, they had follow-up on 118 patients with a minimum of 12 months and a mean of 24.9 months. Now, in the pregnancy world, this is not very long follow-up because it usually takes several cycles for any even normal woman to get pregnant. And therefore, the pregnancy rates in a short term are not that helpful. Also, they asked patients to wait at least 6 months after the intervention in order to try to get pregnant. And then in addition, any patient that had a UFE and had a fibroid that was larger than 5 centimeters 6 months afterwards on imaging went ahead and got a myomectomy. So they did a myomectomy as a secondary procedure in those people, regardless of whether they had symptoms or not. And so many of the UFE patients actually had to wait 12 months because they went through 2 interventions. What are the sort of summed numbers from this? I mean, recognizing that there are a few flaws in that design. So among the patients that tried to conceive, UFE was fewer because some of these patients had secondary procedures and therefore they had not yet tried. They had 26 women who tried, and 13 were able to become pregnant, pregnancy rate of 50%. Looking at myomectomy, you can see 31 of 40 women were able to become pregnant, a pregnancy rate of 78%. You can see that that's statistically significant. The delivery rate among patients was 19%. It's 48% for myomectomy. The abortion rate or miscarriage rate was 64% for UFE. It was 23% for myomectomy. So these relative risks, the relative risk of not getting pregnant after UFE were 2.2 times less likely to get pregnant after UFE based on these numbers. Now, again, there are some flaws in this, so we can't take these numbers as being the gospel. The relative risk not to deliver 1.5, and the relative risk to abort was 2.79. So it's based on this study alone that I currently recommend that women that are interested in becoming pregnant, that are candidates for myomectomy, who have not had a prior myomectomy, should be considered for myomectomy first, because it appears as if the reproductive outcomes may be better, which is also what the Cochrane Review said. So there are a number of papers, if you go out and look in the literature, that say, oh yes, the pregnancy rates are very similar and compared to this old study and that old study. But, really data from a randomized trial is very powerful because you can't compare one study to another. Patient populations are different, ages are different, extent of disease, etc. So when you randomize patients that are all in one population, all those variables get distributed between the two groups, and therefore you're able to draw better conclusions. Oops, go back a second. So if I were to summarize on fertility, I think most people would say that patients that are interested in getting pregnant should try to get pregnant without any intervention. You don't, just because you have fibroids doesn't mean you need to have a myomectomy. I do believe that myomectomy, at least at this stage, should be the first therapeutic choice for those seeking pregnancy. And in our practice, of all the patients we see, about a third of them we recommend something other than UFE. And a total of 8% of patients we recommend for myomectomy, and it's almost always someone who's seeking pregnancy. UFE does have a role, though, still in some of these patients. In cases where there's repeat myomectomy, where the reproductive outcomes can be very poor. Those who are poor surgical risks, very obese patients, patients that have comorbidities, difficult to resect fibroids, or patient choice. Proper informed discussion and consent is important, and I'll tell you this adds 20 minutes to every one of my consults if a patient is interested in pregnancy, because you really have to kind of go through this, look at their situation, and make a recommendation based on what would be best. And we definitely need more study in this particular area. Still, having said that, there was an ACOG practice bulletin that was based largely on the evidence I just presented that suggested that there's good and consistent scientific evidence, or level A evidence, and that based on long and short-term outcomes, uterine artery embolization is a safe and effective option for appropriate selected women who wish to retain their uteri. So the exception they give is for women who would like to become pregnant. They still suggest that it's experimental, and I think there's some logic behind that argument. But this really does say that women should be offered this as an option. And of course, in many places in the country, they are not currently being offered this routinely. So let me just spend a couple of minutes to finish up talking about patient selection, what a little bit of the evidence would say about that. And so the question is, who do we treat with UFE? Well, first of all, we only treat patients that are symptomatic. UFE is appropriate for most patients with single or multiple fibroids. The location of fibroids is only a relative consideration. There are some fibroids that might better benefit from surgery, but there are very few circumstances in which that's the case. And I think the important thing is to consider each patient in the context of their reproductive plans, comorbidities, preferences, etc. Oops. So here's a series of patients. So with a 3 or 4 centimeter fibroid all the way up to about a 14 centimeter fibroid, fibroids of varying sizes. Now, to be honest with you, once fibroids are this big, I began to suggest to patients they might want to consider surgery, although this patient actually responded quite well and did very well. But if a patient, for example, wanted to get pregnant, they would clearly have a difficult time getting pregnant with that fibroid there. Looking at multiple fibroids, here's a series of patients increasing size of uteri. This is about a 12-week size uterus. This is about the same size. Then it gets bigger up to about 18-week size. This is 22-week size. This patient's navel is right there. So we really can treat, all these patients were treated with embolization and all did well. So what does the literature say? Well, based on the Fibroid Registry, which was a study of 3,000 patients looking at quality of life scores and symptom scores at a year, The following are predictors of good outcome. If a patient presents with a primary complaint of heavy menstrual bleeding, as opposed to pain, discomfort, pressure, they're more likely to get a good outcome. Now, it is true that 70 to 80% of patients that present for fibroid embolization or any fibroid therapy have menorrhagia as either a chief or a very important complaint. But this was the primary presenting complaint in these patients. Smaller uterine size probably correlates with better patient satisfaction. And by that I mean less than 20-week size. So if your navel is below, if your fibroids go up to the navel, then that's about 20-week size. If they go above it, then that's for every finger breadth above your navel, it's an additional week size. Smaller dominant fibroid size, probably I typically say less than 12 centimeters, but I certainly have treated larger fibroids. But smaller dominant fibroid size generally is associated with greater shrinkage and greater patient satisfaction. Multiple fibroids will work better in an individual patient compared to a patient of similar sized uterus with a single fibroid. So if you have one fibroid, 20-week sized uterus versus 10 fibroids in a 20-week sized uterus, it's likely the patient with multiple fibroids will do better. The fibroids will shrink to a greater degree, the patient will get a better anatomic improvement, and they're more likely to be satisfied. Deeper fibroids, intramural and submucosal fibroids tend to shrink more, tend to be associated with higher patient satisfaction. And in this particular study, younger patient age did better, although it was not a strong trend. Which patients are less than ideal? Well, very large submucosal fibroids probably are less than ideal, mostly because of their risk of fibroid expulsion, which can be associated with discharge that can be either chronic or acute. It can become infected. It's associated with very significant cramping pain, dilation of the cervix. It can be associated with heavy bleeding. This is a potential leading cause for sepsis in that when the cervical mucosal barrier or mucus barrier is broken, bacteria get up into the uterus, you get infection. So we really don't like fibroids to come out, and large submucosal fibroids are more likely to come out. So that may be a group in which at least that has to be discussed frankly and let the patient understand what they could potentially happen. And many of these very large fibroids that try to be expelled result in hysterectomy. Large pedunculated serosal fibroids, particularly with a narrow attachment. Now, this is a little bit old news in that there are some studies out now that would suggest that large pedunculated serosal fibroids probably can be well treated, even if they have a narrow attachment. The concern with the narrow attachment originally had been detachment of the fibroid from the uterus associated with infection or other kinds of problems. And that has happened rarely in a couple of cases, but it has not really been very common at all. As I indicated, very large single fibroids may not be best treated. And cervical fibroids are a subclass of fibroids that most operators would say are not as well treated. And there was a recent paper by Dr. Kim from Korea in which he reviewed the results on a small group of cervical fibroids and did not have great results, and certainly not the equal of other types of fibroids. Oops. So if you take the anatomy away and you just ask the question, which patients are best for UFE? Well, ideal patients are those who are done with childbearing, so you don't need to worry about future fertility. Those who wish to retain their uterus or to avoid a major surgery. Those who are poor surgical risks. Those with prior pelvic surgery, like prior myomectomies, they tend not to be very easy operations for hysterectomy. And patients wishing minimal recovery time. Now, I will say that recent developments in surgery, spurred in large part by uterine fibroid embolization, have helped reduce recovery time. I mean, most major cities now have fibroid centers, and they have laparoscopic gynecologic surgeons who are doing this either robotically or laparoscopically and are getting good results. And the recovery time from a laparoscopic hysterectomy is about 2 weeks, whereas a uterine embolization is probably 8 to 10 days. So they are not that different. So we probably do best in a group that says, well, I don't want to lose my uterus. Why should I? For a patient who doesn't really care, some of them may, I think, find a minimally invasive hysterectomy to be an attractive option. UFE is a second choice, I would say, in patients who are being treated for infertility or who have a strong short-term interest in pregnancy. Usually we use the term, are you interested in getting pregnant in the next 2 years? If there's a vague future idea about pregnancy, it may be that UFE is reasonable, unless the patient is very young. If they're 20 or 25 or 28 and they say, well, I may want to get pregnant in the future, I typically would still recommend a myomectomy for them first. You have to be a little bit careful, though, because if you have someone who is not interested in getting pregnant for 5 or 8 years and they do a myomectomy, they could have new fibroids by 5 to 8 years, and therefore either require a second myomectomy or an embolization or something else. So it can be difficult, particularly for women that are young, that develop fibroids young. Patients that have a strong interest in the most durable treatment, they say, I want to have one treatment, that's it, I never want to do this again. Hysterectomy, I think, is preferred. Patients with resectable submucosal fibroids, just to avoid any fibroid expulsion. Hysteroscopic resection. Now, the trouble with this is that usually the limit is about 3 or maybe 3.5 centimeters. So most of the larger submucosal fibroids are not really resectable. Oops, sorry, let me just put that last slide up there. Hold on one second. My mouse does not really work, so with this program. All right, let's just try this last slide here. So I would summarize this by saying that fibroid embolization has become established as a safe, effective, and durable procedure in the short and midterm. There's no question about that. Now long-term data is out, and it is clear that this is at least probably the equal of myomectomy in terms of durability. Uterine fibroid embolization is the best choice for those patients who are done with childbearing and wish to avoid hysterectomy, and that it's minimally invasive, is a shorter recovery, shorter return to normal activities with a very similar satisfaction long-term. Reintervention rates, though, are going to be higher, and therefore the patient should know that there is that option. Every patient that I see, I tell them about what the long-term impact may be. And myomectomy, I think, may still be preferred for those who have strong interest in future childbearing. So with that, I thank you very much for your attention. I'd be delighted to take some questions. Are there any questions? Okay, someone's raised their hand. I don't know how to do this. I'll let somebody else do it.
Let's see. Looks like EMA has raised their hand. EMA, you want to ask your question? Well,
can you hear me? Hi, it's Steve Huffman here. They might be having a hard time because they might be muted.
Can you hear me?
There.
Yeah, we can hear you now.
Okay, all right. Yeah, thank you for the talk. That was excellent. I'm a fellow at Johns Hopkins, and lately we started doing a lot of uterine artery embolization with gel foam prior to myomectomy to reduce bleeding. And I'm wondering, what's been your experience with that, where you practice, and what are other people doing with respect to combined therapies, and what's the data for that? I'm going to go ahead and mute my microphone.
There's not a huge amount of data on that topic, but uterine fibroid embolization initially was begun for that purpose back in 1991. So the gynecologist at the Hospital Lariboisière in Paris went to Jean-Jacques Merlin, who's sort of a very well-known neurointerventionist of the day. And they said, we have a terrible time with bleeding with myomectomy. Is there anything you can do? And he said, well, we embolize meningiomas preoperatively, so maybe we could try that. So they did. This is, 30 years ago, or 20 years ago, I guess, at least. And they started doing the procedure, and interestingly, they found that patients did very well, and their symptoms often went away while they were waiting for surgery. But it did work very well for those who underwent myomectomy. There have been a few small studies on this. I don't have them off the tip of my tongue, but there have been a few small studies looking at that. We have done that as well. We don't use gel foam. I understand the logic, why people would think they should use gel foam. I'm not entirely sure that gel foam has been proved to have good patency of the uterine arteries afterwards, because gel foam resorbs, but it does cause a fairly intense endometrial reaction, or not endometrial, endovascular reaction, and I am concerned there may be some long-term occlusions of vessels. And so there's a guy named Nigel Hacking who presented some work in Europe about 2 or 3 years ago, and I don't believe it's been actually published in a paper, but he looked at a group of about 180 or 200 patients that had undergone gel foam embolization, because that's how he does it. He just rams in gel foam plugets or a slurry. Procedure takes him just a few minutes, and he was getting great results. It does infarct the fibroids, but he was an MR subsequently. He was noting a lot of these patients' uterine arteries were not patent. So, Having said that, if we were to do it, we usually do PVA embolization. It works very well. We usually use it mostly on super large uteruses, 20 week size and above, who might be very difficult myomectomies. And I think that is not widely used technique, but I think that there are a fair number of places around the country that do it. I do also know that Mike Hallisey's group up in Hartford, Connecticut, they were doing actually preoperative embolization for hysterectomy in order to reduce blood loss, and the surgeons loved it. It was apparently a lot easier to do a hysterectomy after you embolize the uterus. That seems a bit overkill to me. Okay, other questions?
Yeah, hi, Dr. Spies. It's Steve Huffman. Can you hear me?
Yes.
One thing I wanted to ask was how you change your recommendations to patients who you're treating for adenomyosis as opposed to fibroids.
Well, I didn't get into all the evidence in adenomyosis because, number one, the evidence is not as strong for adenomyosis, but there are enough sort of small case series out there. We published a couple. There have been quite a number in Europe and in Asia that would suggest that adenomyosis can be well treated with embolization, but there's some limitations. I usually tell patients that rather than the usual 85 to 90% chance of having their symptoms improve, maybe it's 80%. If they have a lot of fibroids and a little bit of adenomyosis, it's probably equivalent to having just fibroids alone. But if they have a very diffuse and severe adenomyosis with no fibroids, then I think their chances of improving are significantly less. But on average, I'd say it's a little bit less than fibroids across the board. The problem with adenomyosis has been, or the concern has been, recurrence. It's hard to infarct adenomyosis. It's normal tissue mixed with abnormal tissue. The endpoints are more difficult to determine. And so we don't typically get all, or even sometimes even a portion of the adenomyosis to infarct. And if it doesn't infarct, then it's likely to come back. So what typically can happen is it shrinks. So instead of a junctional zone being 3 centimeters, it goes down to like 1.8 or something. But then 2 or 3 years later, it comes back. So I usually tell patients that have diffuse adenomyosis with no fibroids that they'll have an 80% chance of improving. Then I anticipate that they'll have like a 3-year recurrence rate of maybe 30%, might be as high as 40%, depending upon the paper you read. And then the likelihood of needing additional intervention over the 5-year interval is significantly higher than it would be for fibroids. There's also something new that's come out of Korea. Dr. Kim, who's done a lot of work in this, fibroids and also adenomyosis, uses what he calls the 1-2-3 technique. And so what they're doing is they're using very small PVA. They use PVA only in Korea. So they're using 100 to 200 PVA. On a given side, they'll put up to, I think, 3/4 of a vial, very small. Then they will take the next step up, and they'll start using 200 to 300. I think they put like a vial in it. And then if they need more, then they would go to 300 to 500. So they call it the 1-2-3, 100, 200, 300. So it's a stepped approach using small to big embolics. The idea being that deeper penetration of the embolic was more likely to cause infarction. Infarction is correlated with better outcomes, and therefore they ought to do it. The only little limitation in this is that adenomyosis tends to have patients tend to have more pain than uterine fibroid patients. And the average length of stay after this procedure is like 4 days in Korea. So I just spent a week in China doing cases, and their average length of stay is probably 2 or 3 days, mostly because that's the way their hospitals work. There's like no expense associated with them. And what they deal with, their budgets are determined by hospital census, so the longer people stay, the better it is. So you have entire families moving in for a few days while they're being treated. So it's very hard to sort out the length of stay issue. But if I am a little concerned that approach might cause a lot more pain. Other questions?
Great, thanks so much. Are there any other questions?
Hi, I had a quick question, Dr. Spies. I was wondering if you could speak to the current knowledge on why pregnancy seems to be affected after UFE.
Well, there have been a couple of reviews that have come through that I've looked at that are not yet in publication. So there are several potential things. Number one, there's the whole issue of ovarian reserve. In other words, does UFE routinely reduce the reserve of the ovaries? Now, if you look on average, say in the REST trial, there is a diminution of ovarian reserve both for embolization and for hysterectomy if they retain the ovaries. It's modest, but it is seen in both. They concluded that it was slightly worse for embolization, but I'm not sure that's actually entirely correct. I also think that most of these early studies that were done were with very aggressive endpoints of embolization, and you do not need to do complete occlusion of the uterine arteries during embolization. And if you don't, then you're less likely to have embolic go over to the ovaries. In other words, once you start to see opacification of ovarian vessels, it's time probably to consider stopping your embolization. The studies to date, though, suggest that there is a moderate chance of reduction in ovarian reserve in women over the age of 45. There's relatively little evidence that it occurs very frequently at all between the ages of 40 and 45, and there's no evidence to suggest that it is reduced under the age of 40. Now, under the age of 40, FSH, which is the typical marker, is not a very reliable marker. It doesn't really start to increase in suggesting decreased ovarian reserve in women until they're in their 40s. So it's used commonly for older women that are infertility patients, but it's not that great for 32 or 34-year-old women. So anti-Mullerian hormone is a better measure, and there are just not any good studies yet in that patient population in that age range. So ovarian reserve is a potential issue, but if you're 34, 36 years old, you have a reasonable embolization, I don't think it's a very big factor. I personally believe, although there's not any evidence to this, that the residual anatomic distortion of the uterus related to an embolization is much greater than it would be with myomectomy. I also think that there's a chance that there's endometrial ischemia or potential injury to the endometrium. If you have a fibroid that has a large surface on the endometrium, that endometrial surface may slough away. You'll end up with a normal surface area, and that would cause abnormal implantations or failure to implant or other kinds of things. So I think it's more that there are still lots of fibroids there, a lot of anatomic distortion. The endometrium may be affected, and less likely that it's the ovaries per se that's the problem. But there isn't that much data to really explain it. I will also say that post embolization, there may be a somewhat increased risk of some postpartum complications or pregnancy complications. Postpartum hemorrhage may be a little bit higher than normal women. There may be a greater likelihood of accreta or placental abnormalities, just as there are after myomectomy. So I'm not sure it's any better than myomectomy in that regard, but it is still it still could be potentially an issue. But I would say that's more or less the extent of what we know on the topic. It's very hard to do these studies. There just are not that many patients that are getting pregnant after this. There are not that you have to do a huge study in order to look at natural pregnancy rates after this. It just is. It would be hundreds and hundreds of patients. So.
Hey, Dr. Spies, I have a question. You mentioned earlier that your discussion of the risk, benefits, and adverse events during your UFE consultations can be lengthy. Do you like to quote numbers, statistics to patients, like re-intervention rates and stuff like that? And if so, which do you find the most helpful for the patient?
I probably would say I do. Every single patient. I have a little flip chart I use in the clinic. Let me just go back up here a second here. See if we can find that chart. I think that this paper just came out in AGR last month, and wrong table. Hold on. There it is. I'm having difficulty moving my mouse, so I'm sorry. I think this is a reasonable representation of the risks associated with uterine embolization. This is not exactly the list I use. I use something very similar to this. So what I say, I can actually quote this as I say it all the time. I say that the likelihood of going into menopause is between 1 and 10%, depending upon the patient's age. It's less than 1% under 40. It's 10% or greater after the age of 50. I say the fibroid passage is between 2 and 5%. Now that this paper has just come out, I lean more towards 5%. But I look at the individual patient, and I might say your particular risk, I think, is higher, 10, 20, 30%. Then I talk about the risk of hysterectomy. I say it's 1 in 200, which is about what this is. And then I don't talk about infectious complications separately because they really are, the urinary tract infections, there really are not that many serious infections unless there's fibroid passage going on. The next thing I talk about, let's see, is pulmonary embolus, 1 in 400. Then I say that there's about a 1 in 1,000 chance to have an angiographic complication related to the puncture site, which is our own experience. There's about a 1 in 1,000 chance of having a malignancy that we do not detect. We think it's benign on the imaging, but it's not. And I've actually personally had 2 cases of leiomyosarcoma that were high grade that we thought were benign over in 3,000 patients. And then I tell them it's about a 1 in 8 to 10,000 chance of dying. So I actually have this. I give every patient like a summary sheet when they leave, which is printed, and it has this on it. Part of that's for risk management purposes. Part of it is because I give them a lot of information, and I think it's confusing to people. So having it in writing or having it on your website or something is very helpful for people so they can, when they go home talking to their husband or to their friends or whatever, they can, get a better sense of it. You would think that this would discourage people, but I don't find that it does. I might get too far into the weeds sometimes, but I think that in the long run, it's probably better for patients to be well informed. So that's how I do it. So I also tell them there's a 20% reintervention rate of 5 years because that's our own experience. So that's the number I typically use.
Great, thank you.
Any other questions?
All right. Well, Dr. Spies, I want to thank you so much for being our first lecturer in the new evidence-based IR lecture series. That was phenomenal, a great way for us to start. And thanks so much for taking time out of your evening. And to everyone who joined in, thanks for logging in.
Yeah, thank you all. This is a great endeavor, and I appreciate all your efforts. It's you really are rejuvenating us, and it's great. So good luck.
Oh, thanks. Great. Thanks again, Dr. Spies.
Happy holidays.
Thanks. You too.